For in the name of the Almighty, most merciful and beneficent, I have shown you the 5 chest X-rays, plain, and you have to answer the questions asked by the examiner if it is put on in front of you. The first X-ray, these are the answers, probably. Probably some will agree and some will not agree, I don't know. But this is the correct answer, is this. You have actually written on the piece of the paper, if it is possible, then it is very good to match it, whether you gain the marks or not. First patient which I have put on was a patient undergoing herniorrhaphy actually, planned for herniorrhaphy and had done X-ray test as routine. Now, these type of the medical fitness endorsed by the medical officers or internists are usual. Now, this was the X-ray which was done. The correct answer in this, but you have to assess this patient by all parameters. The exercise is one of the most important investigation. Here the requirements are not fulfilled. The requirement was the patient X-ray should be done in the PA view. Yes, it is PA view. She should be straight and still, and he should be standing. Yes, but the patient should be deeply inspired and hold the breath properly. And it is seen here. This is the first, this is the second costally cell, and this is the third one, this is the fourth one. Hardly it is fifth costal cartilage, the dome of the diaphragm is here. And patient has expired here. The expiration film. This is the expiration film in which it is shown that here the congregations of the bronchoscopic marking which are not visualized properly. These should be separated bronchovascular markings. Here it is not seen at all. At all it is not seen. This is the part of the middle mediastinum here is shown. On the routine radiography, the patient should inspire, first of all, and hold the breath properly. If he is not holding the breath properly, then the film will be gone. The other parameter you carry, the cardiomegaly is visible here, for example. The wrong impression was created. On the other way, the other things are also not clearly visible. In only one aspect you are going for the expiratory film. What is the indication in which the expiratory film is required in PA view? And one is the condition in which there are small pneumothorax. And the expiratory film is needed. Inspiratory is needed as well as expiratory is needed. So this part is suspected. Here there is no bronchovascular markings. Look at this. Expiratory film, it is not inspiratory film, first of all. Secondly, it is the X-ray was taken because of to see this area, sir, and it is shows about 1/3 of this part consists of the ear. So it is a small, you can say, pneumothorax which is present in this case. The patient doesn't know about it. Probably he is asymptomatic. He doesn't know. So other investigations you might done in this case are the same one. I will say that you need the inspiratory film and compare it with the expiratory film in standing position. Lateral view right should be done, or if it is possibly the HRCT should be done. And the clinical examination will reveal there is a definitely tympanic nodes in this area and there are no breath sounds. In this small pneumothoraces, actually we wait to see the patient is symptomatic or not. If the patient is not symptomatic, we do not do anything. We just follow up this patient because this is a small pneumothorax. So that is why we wait for it and then we investigate on the what is the cause of this pneumothorax. So all investigations which causes the pneumothorax, small pneumothoraces, should be investigated. Other than that, these possibilities we will do. This is the answer. There is expected film and showing the small pneumothorax. The other parameters should not should be fulfilled properly. We cannot comment on any other parameter of the X-ray. The second was a 25-year Taylor with abnormal electrocardiogram. Again, the answer is this: he has got abnormal electrocardiogram. 25-year-old Taylor. The important point in this case is this is the spine looking like this. The spinous process is going down, cervical, and then thoracic spine moving like this. There is scoliosis of the spine. Probably scoliosis in most of the cases, more than 70% of the cases, associated with the kyphoscoliosis. So kyphoscoliosis is actually, because lateral view is not present here, the patient is a kyphoscoliotic. This is the answer of this skygram, sir, and the other investigation we do. The lateral view should be done. The clinical examination is a very important one. Count the spine from backwards and see how much it is. Why the abnormal ECG is in this case? Because of the kyphoscoliosis. Even the clinical examination reveals the precordium reveals the abnormal sounds. Abnormal sounds can be heard, although it is not actually pathological. It is functional type of sounds, and also we find the same thing in the electrocardiography, excess deviation, and the other STT changes can be present. So it dodges that. That's why the cardiologist, because they have not seen the spine. So the thing is this: in this case, the answer is kyphoscoliosis, and should be investigated further for the cause of the kyphoscoliosis. This is the short answer which I can give. The third X-ray was a 22-year-old diagnosed recently as stage 3 hypertension, and he has soft systolic grade 3 murmur at the A1 area. Now see all things which I have already told you in my sessions, which I have actually given tutorials on the radiology. If question is put to me, I will see all the parameters, requirements, etc. And after doing this, and coming to the here, this is the first rib, this is first rib, this is the second rib, this is the third, this is the fourth, this is the fifth, sir. And this is the posterior attachments which is going on here. Now here you see that this is disruption of the lower border are seen here in these ribs. Disruption. Now these are the rib notching. Although it is very difficult finding. If you use the magnifying glass, you can appreciate the irregularity of the border here in this condition. This is called dog sign, sir, and it is seen only if the dog sign is present with this type of the scenario which you have given me. The one diagnosis can be made, and that is coarctation of aorta. Although the rib notching or dog sign can be present in other conditions as well, but if it is with the soft systolic grade 3 murmur, because it is associated with the bicuspid valve. And that is why I have said that this is the coarctation aorta causing the rib notching. It is associated with the bicuspid valve. It may be associated with the aneurysm of the circle of Willis, belly aneurysms. These are the complications associated with this. So further investigation should be done. In this case, will be the echocardiography will show you where is the location of the coarctation, proximal or distal, and be managed on these grounds, whether it is proximal or it is distal one. So surgical correction is needed in most of the cases, followed by the pharmacology, secondary prevention, pharmacological therapy. The other was a fourth X-ray of 45-year-old weightlifter, he was trainer, having upper chest pain and the left shoulder pain with the occasional giddiness. Giddiness is the layman terminology. Maybe he wants to say dizziness. It is not true vertigo, but it is outbalancing phenomena, giddiness, occasional. When he lifts weight, probably because he has training, he is giving a training, sir, and that is why he may possibilities associated with this giddiness. But what is the abnormality? After seeing all these parameters, the normal requirements, etc., I am focusing now because nothing is abnormally seen here. So I will do this. Now these are the cervical vertebrae which is present here. The cervical vertebrae is the answer. How it is cervical vertebrae? How will you count it down? And this is the first rib, this is the second one, this is the third, this is the fourth and fifth in the right side. This is the first one. Above this is the rib which is coming out from this. This is C7. It's coming out, it is always, cervical ribs is moving outwards, not inwards. It will not make any joint, and it is always widened at the proximal end, and the distal end it is narrow. So it is compressing the foramina, which is the foramina transversarium, and it causes the pressure on the C7, C8, T1, and that is why the pain occurs on the right shoulder, sir, and on the upper chest. And this occurs because of the vertebral arteries passing very, very near to it. If it moves its head here, so the compression can be caused by this cervical rib. It is complete cervical rib. There are two types of the cervical rib. One is complete, one is incomplete. It is a unilateral cervical rib which is causing problem in this patient. So other investigation can be done. The cervical spine X-ray, the MRI of the spine can be done to ascertain the diagnosis. The stages of the cervical, you can do the MRI. So this is the answer of 4. And the last one was the 32-year-old having the history of diplopia and increased lethargy. Patient of diplopia and increased lethargy. After very, very close observation, which I have seen in this X-ray, the requirements are fulfilled, etc., etc. Everything is okay, fine. The thing is this, which is abnormality to me, which I classified is the upper part of the middle mediastinum. The aortic knuckle is there. Other than that, this is a part which is abnormal. One part is here, and one wall is here, and one wall is here. Both walls are irregular in shape. So this is non-muscular shadow which is arising here. Because it is arising in this fashion, then one part is ballooning out, the other part is flat. It is, sir, called in the radiological language the Selling sign. The Selling sign is the sign in which the thymoma is present. This is a thymoma present in the patient of 32 years old who had got the predominant type of the myasthenia gravis affecting the eyes rather than the body. We can confirm it by the lateral view, we can confirm it by HRCT, we can go for the other tests of the antibodies against the acetylcholine receptor antibodies, etc., to confirm our diagnosis. Most important thing about the thymoma associated with this condition is this: if you remove the thymoma, there are 80 to 90% remission in the clinical scenario. Very benefit. The patient are much benefited when they have got the ophthalmic type of myasthenia rather than the somatic type of myasthenia. The benefited mostly thymoma, if it is removed, it benefited the most of the patients who have got predominant ophthalmic problems of the eyes, extraocular muscles. So in this condition it is very, very beneficial. Now these are the answers, very short answers which I can give in this time about the 5 X-rays which I have shown to you. Probably you like my answers and my 5 presentations which I have given, and I think you have diagnosed already. Give your marks only, yourself 2 marks each X-ray, for example, and you will obtain, inshallah ta'ala, probably 8 marks. I hope so. Wish you good luck. I will again give you the quiz of 5 X-rays next time, first of all, and then answer as a candidate to you. Goodbye and wish you good luck.